Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 5 conversations from Season 3, Episode 43, our look at the future of combination therapies, plus, from the more recent vault, a section of a May 2022 episode on NASH drug development that presages the topics we discuss in this week's episode. This conversation starts with Naim Al-Khouri confirming Mazen Noureddin's comment from earlier that a 6-month study will be limited in terms of measuring maximum efficacy. Naim continues to note how strong and consistent relative fat reduction was in patients in the study and shares his hope, based on these results, that in the future, robust combination therapies might cure, in air quotes, patients by regressing fibrosis and melting virtually all liver fat. Jorn Schattenberg asks how often we would track patients with NITs in a trial like this if the backbone agent were approved, the kind of futuristic design Mazen mentioned at the end of the previous conversation. Mazen suggests a protocol. Louise Campbell comments on patient adherence benefits of a therapy that produces rapid, measurable results for patients, and then the group turns to the opposite question. What should be the futility index? That is, how long should a patient receive a therapy that is showing no benefit before we stop it? In the last section of this conversation, I comment on the benefit of incorporating multiple liver targets or modes of action in a disease as multifocal and complex as NAFLD and NASH are. Naim and Jorn agree and add comments of their own. This conversation considers in broad terms the practical, clinical, and commercial issues that will frame the future of frontline drug development for the entire range of NASH patients, focusing both on drugs and, in a sense, diagnostics. It leaves a great deal for all of us to ponder. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn and Facebook discussion groups.
Naim Al-Khouri.
Mazen, I totally agree that the duration was short, and we see that even with the weight loss with semaglutide, about 7 to 8%, as opposed to 16-17% that we saw in the Step 1 program. This was, with the higher dose 2.4, which was indicated for obesity. So we anticipate that these patients will continue to lose weight, and maybe that will enhance efficacy. The other point is when we looked at other fibrosis biomarkers, including ELF and MR elastography, we did not see a signal, but again, I think this has to do mainly with the duration of the study. So 6 months, to see change in MRE is probably too ambitious and not realistic. I think, the exciting thing for me is to see rates in the 90% and that 30% relative reduction. And really, I'm hopeful that we get to a point with these combination therapies that we start talking about a cure for NASH in some patients, where there's really no evidence of the disease whatsoever, where there's not enough liver fat to call it NAFLD, where the ALT and the AST are normal and the liver stiffness is back to a normal range. And we can tell, some of these patients that, hey, at least for the time being, it seems like there's not anything to call NAFLD anymore. So that's the hope in the future.
Jorn Schattenberg.
That's great. I'd like to revisit Mazen's comment on the futuristic aspect of this trial. And clearly, the short duration does limit you with the number you repeat these biomarkers. But one of the weaknesses in histology, we have a start and we have an end. We have 2 time points over, let's say, 48-week trial. If we move to the next level and do NITs, Mazen, how often would you actually want to see these NITs being repeated to actually see, a time response that maybe we can learn from too? What do you think is feasible from a financial aspect? Also burden for the patient, how often do they have to come back to the study center, go to the MR or something? What's your view on this? How often are we going to get this in a 48-week trial?
Mazen Noureddin.
That's a big question, Jorn. I will try to use an example, which is this trial. Let's say I want to design it as phase 2B. Now, I'm not going to say phase 3, so I don't get in trouble with certain people. Again, we need more evidence. We need to correlate with outcomes, and there works are being done with Litmus, Nimble, Neil, NIT, and others on that. But let's say this study, if I want to design it in this patient population, I will probably do it for 9 months or a year on these patients, let's say 2B3, and I will get baseline 6 months for interim analysis and on an end of the year. I would think that eventually we're going to reach a combination of NITs, meaning 3 to 4, that will determine both change in NASH and fibrosis. And we have examples now. Again, I'm not trying to sell anything or biased toward anything, but let's say MAST or FAST, we get them at baseline, 6 months interim analysis, and then end of the trial, and show that multiple NITs are heading the right direction. And many of them now are showing correlation with outcomes. And we can show eventually that the improvement in these NITs lead to improvement in outcomes. And I think, and realistically, from cost standpoint, I think 3 time points within a year could be sufficient eventually. Of course, with smaller trials with a proof of concept that you really want to see the needle moving on anything or not, you might condense that with shorter duration and more NITs to have more confidence in this trial or the MOA.
Louise Campbell.
I think you also, Naim, when you were talking, actually showed a really good benefit in or reduction in the AST, ALT and FibroScan over that short period. I think the ability to show real-time results to patients short-term really is a motivator to continue lifestyle modification in addition to the medications and to stay on the trials, but also in going futuristic, to be able to engage people in standard of care as this becomes that type of future quite quickly. That ability to show real-world results and how it benefits, even small changes, and those medications has the potential. And I think some of the outcomes that you described fit directly into that short-term reinforcement of it is working. That sounded to me as a huge benefit that you can take into the real-world patient population and get immediate turnaround on their behaviour change. Because we do want to reinforce that any of these treatments in combination with lifestyle modification, because we might be treating one person with a drug, but we're treating the whole family because a lot of family members may be affected by the same condition and genetics. So it's more of a holistic with combination.
I totally agree with you, Louise. And the other point is also to look at futility of a drug. We anticipate to have FDA-approved drugs that will be costly. And I think probably 6 months is a reasonable period of time. I mean, when we look at A1C for diabetes, we do it every 3 months or so. There's no reason to do it more often than that. And the same with, doing MR elastography, PDFF, looking at futility and response to treatment. We'll learn from the phase 3 trial designs before we have the drugs on the market. But for a drug like resmetirom, you would anticipate reduction in MRI, PDFF, ALT, lipids, and you're going to have patients in clinic that you assess at 6 months and don't see any of the above. And in that case, the drug is futile and there's no reason to continue if you're not reducing your liver fat and your ALT is the same as you started. And I think 6 months is fair. Anything less than that would be too short. And then if you see some promising efficacy at 6 months, you said it also earlier that we have to make sure that that response is not plateauing and that we continue to see improvement at 1 year. And then maybe after that, we start doing yearly assessments. Of course, patients with cirrhosis will need different monitoring. This is for non-cirrhotic patients.
Can I just ask, on the futility question, if you were to be able to look back in the clinical trials that you're doing now to pick up clear signs of futility at an earlier time point, would that be a benefit given the cost of these medications?
Yeah, I think it's absolutely needed to realize also when to say a medicine is not working, because when we look at the histologic response, for the most part, we're between 20 to maybe 60% response, whether you're looking at NASH resolution or fibrosis improvement. So there would be non-responders, and this is easy with a medicine like semaglutide, right? If you've been on it 6 months and you haven't lost weight, probably it's not going to be effective as a treatment by itself. I think with resmetirom, we're learning the importance of MRI, PDFF, and with every drug, there will be a combination of biomarkers, as Mazen said, that will help us decide when the drug is working and when it's not. But we have to think about it both ways. Obviously, we want the drugs to work for everyone, but also we have to think about the cost to the healthcare system.
So, Naim, first of all, you described this as your baby. At the risk of sounding like I'm saying something facile, your baby's really beautiful. This is a beautiful baby. Having spent my life in a whole bunch of drug areas, none of which were NASH, there are some underlying principles here that make a ton of sense. When you look at the pharmacokinetics of drugs, it turns out that the level that you require to get to peak efficacy is whatever it turns out to be, or significant efficacy. And then above that, the rate of safety and side effect issues rise a lot faster than incremental efficacy does. So there is a compelling logic that goes, if I can use lower doses of 3 different medications, that should have the effect you noted on safety and side effects in addition to whatever value it has for efficacy. And I think that's great, number one. Number two is, I remember the first time I saw a map of the liver in the context of NASH, I was struck by exactly how many different places there are that you can attack. We talk about the idea of taking shots on goal. The problem is the liver has 8, 9, 12, 15 different goals. You're not going to want to shoot 4 pucks at the same place. You're probably going to want to invest in 3, 4, 5 different therapeutic targets. So if you can do that at low dose, then you wind up with a safer world and you wind up with a better shot at meaningful efficacy, because you don't need to hit every target with every patient. But, when you talk about a 95% estimate in 3, that says to me that you're getting getting at least one strike on each target from 90% of your patients, which is pretty exceptional if you think about it. Hey, am I reading that right?
Yeah, I think you nailed it. Cilofexor at the 100 milligram caused more issues with pruritus, increase in LDL. So using a lower dose is helpful in terms of mitigating the adverse events. But we're still seeing potentially some of its anti-fibrotic effects, which is exciting. We know from the obeticholic acid data that there's a robust effect on fibrosis regression with the FXR agonists. So if we extrapolate this with cilofexor and show that we can mitigate the main adverse events of pruritus and increase in LDL, I think that's exciting. Firsocostat is a very potent medicine, and it's not the only one out there. So there are other what we call acetyl-CoA carboxylase inhibitors, ACC inhibitors, and all of them have a very potent effect on reducing liver fat, and they all share the issue with increase in triglycerides. So in terms of defatting the liver, we are seeing the efficacy, and then adding the semaglutide is helping with mitigating the increase in triglycerides. So as you said, it's both efficacy and also mitigating adverse events with using lower doses of the drugs.
It was very obvious, Roger, if I cut in, it was a very obvious attempt. And I think there's a lot of compounds that could potentially be combined with semaglutide because beneficial effects. And congrats again to both of you to setting this trial up and getting it running.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. The next 3 weeks will be devoted to previewing and then covering the Paris NASH meeting and the EASL-NAFLD Summit. September is a brutal month for travel schedules and, as a result, podcast scheduling. We'll be using some hybrid episode designs, and both Jorn and Louise will miss some episodes. I'll be here for all of them. It will be a challenge and a bit of a wild ride for me, but if you know me by now, you know I love a challenge. So stick with us as we move through the month. If you're in the U.S., enjoy Labor Day. Wherever you are, enjoy the transition to what we hope will be more temperate weather. Stay safe and surf on. We'll see you on the podcast. Bye-bye now.